The broadcast is now starting. All attendees are in listen-only mode.
All right, well, hello everyone. Thank you so much for joining us today for our first module of this learning collaborative, developing cross-sector partnerships to improve health outcomes. We are really excited to have you here today, and thank you for many of you who joined Slack already to start the conversation with us. We are, again, really excited about this learning collaborative. I am from the National Nurse-Led Care Consortium. I'm joined by my colleagues from the National Center for Health and Public Housing and the National Center for Equitable Care for Elders. And so the three of our organizations are jointly hosting this learning collaborative, and we're excited to be with you throughout June. So as you know, we are hosting this learning collaborative as part of the SDOH Academy, which is a collaborative group of NCAs, National Cooperative Agreements. We provide training and technical assistance around the social determinants of health to try to bring information and resources to health centers around providing services for those social determinants. So throughout the webinar today, we are welcoming questions. You can see on the right-hand side of your screen, your panel should have a questions section. So please just feel free throughout the webinar to type in your questions there. You can also use that as a little sort of a chat module for us. So if you have a comment or want to share a thought, please feel free to just type it into the questions and we'll read that out loud as well. And again, thanks again for those who have already joined Slack. We're very excited to begin and kind of sustain a conversation with you throughout this month about some of the topics that we're talking about throughout the Learning Collaborative. During the webinar today, I'll share the Slack invite link again for you so that you can join if you haven't already. But we're really excited to just continue to share resources, and I'm hoping, and we're all hoping as facilitators, that you'll connect with one another as well during this Learning Collaborative. So today is our first module. We're going to be discussing some key considerations and strategies for serving residents of public housing and the elderly. And then that'll be followed in 3 consecutive modules over the next 3 weeks by modules 2, 3, and 4. Today, our main presenters are from the National Center for Health and Public Housing and the National Center for Equitable Care for the Elders. And you'll be hearing from all of the facilitator organizations throughout the Learning Collaborative. So as I said, my name is Emily Kane. I am from the National Nurse-Led Care Consortium. So we are a member organization that that supports nurse-led care across the country. That includes nurses at the front lines of care, but also sort of nurse-led concepts of care. So nursing has always been sort of part of the social determinants of health conversation. And so SDOH is something that we definitely talk a lot about at NNCC and do a lot of training around. We also do policy research and advocacy, technical assistance and support, and we also here in Philadelphia, where we're based, provide direct nurse-led healthcare services. And I'm going to turn it over to Saki, I believe, who's from the National Center for Health and Public Housing. Yeah. Oh, nope. Sorry, hi. Christine from the National Center for Equitable Care for Elders.
Thank you, Emily. So welcome, everyone. I'm Kristie Reading. I'm from the National Center for Equitable Care for Elders, and as our name implies, we focus on training and technical assistance for health centers focused on caring for the needs of their older adult patients. And so we come from an approach that really is interprofessional as well as culturally models of care, and really want to ensure that older adults are cared for in the best possible way, including thinking about where they work, where they get their care, and access to the resources that they have to live and stay healthy. And I think Saki is up next. Thank you.
Thanks, Christine. So yes, my name is I am the Director of Research Policy and Health Promotion at the National Center for Health and Public Housing. And for those of you that aren't familiar, the mission of the National Center for Health and Public Housing is to strengthen the capacity of federally funded health centers that are located in or immediately accessible to public housing. And we do that by providing training and technical assistance, research and evaluation, and services to build outreach and collaboration. We work directly with health centers and housing agencies to improve access to care, to improve quality of care, and to ultimately improve the health outcomes of public housing residents. So we're funded by the Bureau of Primary Care at the Department of Health and Human Services, as is our the other partners on today's call. And I should note that the opinions that we are expressing in these presentations are of our own and do not represent the opinions. So thank you all for joining today's call. We've been working on this and planning this for quite some time now, so we're excited and ready to begin. I just wanted to share a little bit about you all. There are 41 organizations in 23 states that are represented as part of this learning collaborative. And we have a quick poll that we would like to ask for you. We just wanted to get a sense of who. So, Emily, would you mind running the poll?
Yep, the poll is open now. So if everyone can just take a moment to just to vote on that poll. So how many colleagues are joining you today? And we'll let everyone know when we're getting close to our response rate. Okay, so looks like we're good, and we're going to share the results to see. Great, so we have a kind of a mix of folks. Some people are flying solo today, and others are with some colleagues, so that's great to hear and see.
Okay, great. So, so here are some, thanks again for those of you who filled out the survey that we sent a few weeks ago, and here's some of the findings from that pre-learning collaborative survey. You all said that the top SDOH challenges that your patient population faces are poverty, low educational attainment, and transportation. And you also said that the seniors and the public housing residents that you serve are hard to reach because of those SDOH challenges, as well as because, at least for the seniors, they aren't using technology like text and emails and the patient portals in the same way as other patients. And there are some language barriers as well. You also provided some solutions to dealing with those challenges, including the use of community health workers and care coordination to engage and educate and follow up with these patients. We asked you what organizations you currently are collaborating with, and the majority of you mentioned other health organizations like state health departments and hospitals, which is really great. But not many of you said that you're currently working with a public housing agency, and several of you mentioned that you'd like assistance in making those housing connections.
Hey, Saki, I'm so sorry to interrupt, but you're sounding a little distant. Is there any way you can get closer to your microphone?
Sure. Is this better?
Well, that's way better. Thank you.
Okay, great. So so it's no surprise. More than half of you said that time and resources were the main challenges you encounter when you're trying to develop new partnerships. But half of you also said that you're having trouble managing relationships, and a third said you needed to as potential partners. So this was all really great information for us to hear and to keep in mind as we discuss the content of all of these 4 modules, and to make sure that we're addressing those challenges that you faced and try to offer those solutions. But we also thought it would be helpful to present these findings from the survey up front to the group and ask that you all think through the scenarios or the circumstances where you've had to navigate those challenges. Yesterday, I mentioned on Slack that the real value of this learning collaborative is creating a forum where you and your peers can openly share and discuss challenges and solutions, and you get out what you put in. So most of you mentioned that the top 2 things that you're hoping to get out of this learning collaborative is the opportunity to hear from one another, to share learning, and to find out what kinds of innovative solutions that exist in the communities around you. So on today's module, which is
the key considerations and the strategies for serving residents of public housing and the elderly. We're hoping that by the end of this session, you'll be able to describe the health challenges of seniors that are living in public housing, list some examples of key partnerships in successful senior programs, and describe the key considerations for building or expanding successful senior-focused programs for residents of public housing. So we're going to follow the agenda here on this slide. I'm going to provide some background information on public housing residents. Kristie is going to give some insights on the health needs and issues for seniors, and I'll briefly go over a case study publication. But we're going to spend most of the time today hearing from a wonderful speaker. Her name is Sue Vega. She's the program manager at the Center, and she's going to be discussing Casa Maravilla, a senior housing site in Chicago. And then we'll have some time for discussion where you'll be able to share your opinions and your perspectives. Okay, so all of you know that the role of health centers are to deliver affordable, accessible, and quality primary health care to patients regardless of their ability to pay. There are 1,400 health centers. Around 350 of those health centers are located intermediately accessible to public housing, and 106 received a special grant called Public Housing Primary Care Grants to provide care for public housing residents. We have an interactive map available on our website, mchph.org. If you're interested in locating the public housing development agencies or sites in your neighborhood, you can click on the map and zoom in to your community. And if you hover over the buttons, you can find contact information for the Public Housing Authority and some demographic information, or you can get the locations from the UDS mapper. So nationally, there are a little more than 2 million individuals that live in traditional public housing in the United States. About 60% are female. About half of them have less than high school diploma. 17% are elderly. 21% are disabled. And the majority are living at or below the federal poverty level. And typically, because this is a lower income and lower educational status group, you'd expect that they'd also have, poor health status, and that's definitely true. Adults that receive housing assistance from HUD have higher rates of chronic health conditions and are greater utilizers of health care than the general population. And this data is from a collaboration between HUD and the CDC. They linked the National Health Interview Survey with HUD administrative data to get these numbers. And they created a similar report on child health indicators and are planning to release an updated report with more recent data sometime this year. But what I just wanted to draw your attention to is two important things. The first is that if you compare the prevalence of these health conditions between public housing residents and the general adult population, you can see that the differences are quite severe. For all of the health conditions that are listed in this. And the second point is that there's also a difference when you compare public housing residents to other low-income renters, which indicates that there are other factors that are in addition to income that are at play here. So the environment, the conditions of the housing, the safety, the access to healthy food, all of those have a role in shaping health outcomes. And housing has a real impact on healthcare costs. A study in LA showed that the total public cost for someone that's homeless can be around $35,000 a year, while the cost to provide permanent supportive housing can be as low as $7,000. And I know that most of you appreciate the importance of housing, but I'm bringing this study up in particular because it highlights the other sectors that have a stake in the game and have an opportunity to see cost savings when housing and health issues are addressed. Particularly because as you think about developing partnerships, hospitals and health agencies may be the first to come to mind, but agencies that address homelessness and the criminal justice system are also potential partners to keep in mind. Maybe not so much for the elderly, but particularly for public housing residents. And now I'm going to pass it on to Kristie, who's go over some issues for seniors.
Thank you, Saki. So today we wanted to think about some of the issues that older adults face, and I think that when we think about the issues that they face and some of the needs that they have, we really think about some of the common health issues. And as you may guess, as a result of physical changes in aging, that can be influences from genetics, environment, lifestyle factors. One of the top health issues that they face are common medical conditions. And we know that chronic health conditions are the most prevalent and disabling illnesses facing older adults. And so these all have an impact on, and I won't necessarily read all of the common health issues, but it's a long list, and we know that they all relate to SDOH in some way, either through their impacts on health, on their health, or getting access to healthcare services and other resources. And so, for example, you had mentioned in your pre-survey about issues with respect to transportation, and older adults who have chronic health conditions who do need to see a healthcare provider. Transportation can be a really important thing, as well as malnutrition, thinking about food insecurity as another problematic area, and the need to have adequate, healthy food so that they can maintain not only their health but also quality of life. Next slide, Saki. So as I had mentioned, older adults face some common chronic conditions, and we know that even more than a decade ago, chronic medical conditions accounted for over 3/4 of the U.S. medical care costs, and that with the rising numbers of older adults with the same chronic conditions, that the medical care expenditures will continue to arise. Chronic conditions have a substantial impact on quality of life. As individuals are living longer with chronic conditions, care management in terms of managing symptoms, and as you had mentioned in the pre-survey, care coordination, not only with healthcare providers, but also with providers of community-based resources is paramount to quality of life. Next slide, please. And so here I just wanted to give you an idea. When we think about chronic conditions, oftentimes we might think of one condition, and while a large percent of adults over the 65 and older have one chronic condition, we do have over 1/4 who have 2 or more chronic conditions. And so thinking about having to balance the needs and resources for living in a community when you have 2 or more chronic conditions. Next slide, please. And so here, as you are probably all aware, are some of the common chronic medical conditions among older adults. And as you can see, there are several ones. One of the top conditions, arthritis, which is an inflammation or wearing down of joints, has a prevalence of over 40 million Americans, and it can impact loss of independence due to mobility issues. And again, this becomes really important in terms of how they navigate the environment in which they live. It also becomes important in terms of how they can access care, and if they are not very mobile, it's difficult for them to age in place unless the resources and supports are there and there's good care coordination between the health centers and the community-based resources. And so I think that this is just a really quick overview of older adults and what we will be addressing later on in our Learning Collaborative, and I will pass it back to Emily and Saki.
Thanks, Christine. So there's, as she mentioned, and as I mentioned before, there's a considerable amount of research and evidence showing that housing and health agencies and agencies that serve seniors should work together to reduce and eliminate barriers, align agenda and goals, and provide an integrated approach to delivering services. And I'm not sure if I mentioned this before, but the number of seniors living in public housing is on the rise. Around 33% of households living in public housing have at least one elderly member, but only 33% of health centers, at least that are located in or immediately accessible to public housing, have programs that target seniors specifically. And seniors are particularly vulnerable because in addition to the likelihood or risk of having a disability or a chronic condition, as Kristie mentioned, seniors that live in public housing also have limited resources and social support. They often lack access to supportive services that would allow them to age in place. And we know that adults that can age in place have a better levels of cognition, better functioning in their daily lives. They have lower levels of depression compared to other older adults. So we at the National Center developed a report based on a qualitative research study to provide health centers that are interested in either developing new senior programs or enhancing their existing ones with some concrete examples on how to improve their senior patient interactions, increase their access to care, and improve health outcomes for older adults. And I believe Emily circulated a draft of this to all of you, and I hope you, if you haven't had a chance to look at it, that you will. But so I won't spend too much time talking through the findings of the report, but I just want to mention that we interviewed 5 health centers across the country about their senior health programs in public housing communities. And we basically asked them to describe their patient population, their health issues, some innovative senior programs they have at their health center, the partnerships that they've developed, major challenges or the barriers that their patients face, and how they address those challenges. And we also asked them any advice they had for health centers that are interested in health programs. So the report essentially lists all of the programs and partnerships that these health centers engage in, but there were a number of recurring themes, and the first was the importance of providing comprehensive care that integrated a range of social services to seniors, such as the support and services at home program, the SASH program, the program for the all-inclusive care of the elderly, the PACE program. Many of the health centers also noted the importance of both preventing homelessness as well as supporting the existing homeless population through permanent supportive housing programs. All of the health centers noted the major challenge for seniors living in public housing is access to transportation, and I think Christine echoed that, and many of you also said the same thing. Took advantage of the state Medicaid services both for medical and non-medical services. Some of them use dial-a-ride programs or increase their use of mobile health units. Many of the health centers discussed the difficulty in reaching new senior patients, which is again something that you all mentioned in the pre-survey. In addition to the tech issues that you all described, our health centers discussed the challenges of shifting the culture. So many seniors in their communities visited their local hospital for all of their healthcare needs just out of habit, and therefore health centers have to really build trust and create engaging programs to help seniors make that transition and shift how they receive care. In a separate survey that we had done a few years ago, we found that more than half of the health centers expressed that they needed additional staff to provide better senior care. And the trick that health centers in this report did was they created a multidisciplinary team, which is, you know, it's typical for health center using the PCMH model, but using outreach workers in particular was helpful. And some of you said that you use community health workers to do similar activities. And finally, the most obvious, probably, recurring theme is that collaborations are critical. And this is a good segue to our next presentation, which is from Sue Vega at Olivio Medical. We were so happy participated in our study, and we'll be discussing with you today the programs and the partnerships that they have in place at Olivio, And she'll also describe how they built Casa Maravilla through a public and private partnership. So now I'm going to pass it on to Sue.
Good afternoon, everyone. Alivio Medical Center we're a federally qualified health center, a community health center here in Chicago. So for folks who know Chicago, we are just southwest of the city center of what we in Chicago call our downtown. We call it the Loop. And so if you imagine kind of a pie wedge getting broader and broader as it goes further southwest, those are our communities. So we have, you can go to the next slide, I think, here. So we were 30 years old in February. The Alivio Medical Center was founded by a woman named Carmen Velasquez and her partner, Ann Garceland, who was an MD. They have both since retired. But Alivio came about because Carmen found out something that enraged her, and she set about to fix it. And what pissed her off was that she found out that some women in the community, pregnant women, were waiting as much as 6 months to get into the public health clinics in the city of Chicago. She thought that that was just awful, and so she had to do something about it. And so this is some information about us, how we started. These are statistics from 2016. I think there's probably something a little bit newer, and I'd be happy to pass that along. But that's kind of the background. Next slide. So we were founded as an organization to serve Latinos, mostly Mexican and Mexican American, because that's where we are. And from the outset, it was Carmen's vision and mission to make sure that there were bilingual, bicultural providers. So the rule here at Alivio that guides us is that anybody who has regular in-person or on the phone contact with patients or their families must be bilingual. Bicultural is better, but bilingual for sure. So that presents some challenges as we are about 1.5 miles from one of the largest medical districts in the country. So it's been a challenge finding and keeping providers, especially internists who are bilingual, because they're a hot commodity. So we don't believe in using translators. We also now have, because we're also located just northwest of the Chinatown community that is booming. We are also now serving our Chinese population, and so we have providers who also speak English, Spanish, Mandarin, and Cantonese. So next slide, please. So this is a little bit more about just some statistical information. You see, we are pretty Hispanic, and we also have a high level of people who are low income, and some who are underinsured and uninsured, and others who are basically uninsurable. So we see people who are uninsured based on a sliding scale, and we don't turn anybody away. Next. Okay, so that's a little map. So we have 3 comprehensive health centers. One is right next door to where I am located. That was our second center. The original one is just west of here, about a mile west of where we are, and then about 5 miles west of that in the suburban community named Berwyn. We originally had a clinic in Berwyn. It was a small storefront, and now we have a big comprehensive center in Berwyn. We also have 3 school-based clinics, 2 of them in a high school and 1 in an elementary school. So next slide, please. So this is what we do. We have internists, we have family practice docs, nurse midwives, case managers, we have dentistry for children. We're doing a lot more with behavioral health, do case management. We have the 340B pharmacies at each of our sites. I also manage our WIC program and our community health education and promotion programs, as well as family case management, and then my team that does senior and outreach and enrollment for Medicare and Medicaid for older adults and everybody else. But the older adults is where we started. We started with working on Medicare for seniors and people with disabilities, and the program has kind of grown out from there. So next, please. So we've always had some programming for seniors. In the beginning, there was a small respite program. The Senior Advocate Program, which is where I started, was up and running in 2004. We are a senior health insurance program site that is Medicare choice counseling information that we provide to our seniors and anybody who has Medicare, and all of the other programs that are associated with that. And so we do lots of assistance with public benefits programs. We are funded also by the National Council on Aging through their Benefits Enrollment Center program, and the other AAA in suburban Cook County, which is called Age Options, to do outreach for specifically for Latino seniors in suburban Cook County. During the year, we see about 2,000 people that we provide some sort of assistance for in terms of doing a Medicaid application or applying for SNAP and other local programs, because there are some that are county specific and some that are state specific. And NCOA uses a much bigger number, but we very conservatively estimate that we save each of those people about $1,000 a year, and we've been doing that for almost 15 years now. And then we have another 6,000 people who come to the senior center, and I'll talk a little bit more about that. Next, please. So if you can see the photograph here, those are our folkloric dancers, some of them. That was at a show they put on at a local gallery. So at the senior center, we are on the first floor, part of the first floor of a building that has 72 apartments for people 55 and older. The building is owned by an organization called the Resurrection Project, and they're a local nonprofit development corporation. And so the Resurrection Project originally bought the land that Casa Maravilla is on, and we're located on the first floor at Casa Maravilla. The land that we are on used to belong to Alivio. So the director, or the CEO of the Resurrection Project, went to Carmen, who was our founder, and said, we'd like to buy the land if you would consider selling it to us to build housing that's affordable for people in the community, to anchor this part of the community for current residents, for people who are of lower incomes and low to moderate income, to be able to stay in the community. Because we are so close to the city center and so close to the University of Illinois, there's a lot of pressure in terms of gentrification. And it's happening now quite rapidly. So the Resurrection Project built the building. The City of Chicago's Department of Family and Support Services Area Agency on Aging agreed to work with us to establish a senior center and a satellite senior center. So they put in the equipment, the systems, the furniture, and we manage the senior center. And for the past 8 years, Alivio has managed the senior center for $0, and the Resurrection Project has leased back the senior center to the City of Chicago for $0. We expect that that's going to change with the new leadership at the city, and we hope that there will be additional resources so that we can do even more with the seniors. We also, when we started managing the senior center, what we also found was that there were not a lot of people who were officially vendors who could do programs here. So we developed our own. We looked for people, we found volunteers, we helped them to apply to become vendors, and so we've been able to offer things like yoga and meditation and Reiki and other programs that are done by people who are from the community. The instructor for the dance group. So we also do the benefits enrollment program in these other locations. So we are in those other communities: Little Village, Back of the Yards, Bridgeport, McKinley Park, Marquette Park, Stickney Township, Melrose Park, and Berwyn and Cicero. And people come from all of those places. And we've been doing this now for about 6 years. And we did it because during open enrollment, we were getting 50, 60, as many as 80 people a week in this space who were coming for assistance with Medicare choices and extra help applications. And we understood that you can't do that well. You cannot have 80 people coming in the same space and doing it well. It's just too much. And so we partnered with churches and hospitals, other community organizations to provide the services closer to where the seniors live so that they don't have to go quite so far. And we've been able to do some value to their general programming. And we can talk a little bit more if you like about what those organizations are. But you can go to the next slide, please. Next slide. Okay, there you go. So these are the people that we partner with. We talked a little bit about the State of Illinois Department on Aging, the Senior Health Insurance Program, and also the Department of Insurance when we were going strong with Get Covered Illinois, which is our state's version of the Affordable Care Act. And we also work with the City of Chicago Department of Family and Support Services Area Agency on Aging. Age Options, which I mentioned, is the AAA in suburban Cook County. The University of Illinois, we have done a number of collaborations with researchers and other programs where we get students to come and do internships and externships and fellowships with us. The University of Illinois did a program, or there's a researcher who was doing research on dance. He continues to do that, but one of the things that happened as a result of that is we developed a program called Baila, or he developed a program called Baila, and he did the research, and the folks who were participating in the program just loved it, and so they came to me and asked me if they could continue to do it, and so they trained and certified 2 lay people to run the program, and they've been here running the program twice a week for the past 5 years, and we have helped those 2 volunteers to become vendors for the City of Chicago. And the Chicago School for Professional Psychology has sent us students, same thing with Notre Dame University and Loyola. We think it's really important to have students here from a high school, Cristo Rey High School. I think it's really important for us to talk to anybody who's just starting their career about what a wonderful alternative it is to work with older adults. And so we want people to for that to be part of their thought process as they're going through whatever it is, nursing, psychology, medicine, whatever. So anytime there's a couple of students around, we give them the talk. Next slide, please. Can we go to the next? Okay, there you go. So these are some of the core competencies. You have to have Spanish speakers or whatever. You know what? Let me put it this way. For Mexicans and Mexican Americans, people like my father, who has been in this country most of his life, but is still more comfortable in Spanish, I can talk about their needs. I don't know necessarily that this is true for all or most language or other ethnic minorities, but for the Mexican community, for the Puerto Rican community, this is important. Bicultural and bilingual is best, but being bilingual it's a must. It's an issue of respect and dignity, and if people aren't there, then what's the plan? We often hear from other agencies, oh, we want that to be a priority. Well, you know, I think we all understand what priorities are. To my way of thinking, a priority has a dollar sign in front of it. So next slide, please. So with older adults, you know, what happens is the people in our communities often are people who have worked at really hard jobs and are often quite disabled by those hard jobs, and they work far longer and far harder than they should. But they're not people who typically complain. They're happy to have a job. And when they can't work anymore, all kinds of things go wrong. Before the Affordable Care Act, we had lots of people who were in their mid to late 50s, all the way up to 64, who, even if they had the money in their hands, could not get health insurance. And So now with the Affordable Care Act, they have access, but they need a little bit of help trying to figure out what they're supposed to do and how it works. And so we help people not only sign up for the programs, but also how to use the programs. And getting general kind of, especially for immigrants, is kind of a foreign concept. And generally in Mexico, especially in remote rural areas, you don't go to the doctor unless you're really, really sick. And being pregnant doesn't count as being sick. So people just don't know. There are lots of barriers. People get really bad services at the agencies and organizations that are supposed to help them. They often get insulted, treated badly, turned away, and they don't ever go back. So those are some of the things that are out there that we are working on. So next slide. So this is just some information about how our community is growing and aging. And when I say our community, that includes me. I'm 64 years old, and I know that the way I'm going to get services is going to be different than the way my father gets services. And I really think that it doesn't make sense for us to let other people invent our futures for us, and so we have to participate and be active. So you see, these are great big numbers. These are big increases. So we need to get ready for it. Next slide. So these are the challenges, the changes, and the general atmosphere, targeting both documented and undocumented immigrants. These policies are just going to continue to exacerbate poor health outcomes in our communities. That's just the reality. So we have to be able to build trust in our communities, or things will just get worse. But again, in Chicago, we have good news, and in the state of Illinois, we have good news because the leadership has changed, and we're expecting brighter days. Next, please. So these are the questions that people have to ask themselves if they want to grow that segment of their population, or if that segment of the population is growing. These are the things that, these are the questions that organizations should ask. And again, can't do it by yourself. There is no substitute for developing the relationships. You have to go out there and do it, and do what you say you're going to do. Be a good partner, and don't overpromise. That's one of the things that that I always tell folks who work with me is, well, what can we do? We have to be upfront about what is possible. So, and people need to be able to talk about it. If we are doing something, we have to be able to articulate it and let everybody know about it. Next. That's it. So, I know that's a lot of information. It took a lot more time than I thought it would. So I'm happy to answer any questions.
Thank you so much, Sue. It's so great to hear how committed you are to providing bicultural, bilingual services, and as well as how committed you guys are to highlighting the great work, how interesting it is to work with the older populations, with the community. I'm going to pass it on to Christine, who's going to moderate the discussion session.
Great. Before Christine takes over, by the way. This is Emily. Just want to encourage everyone to please put your questions or comments, so we welcome both, in the question pane. And you can also raise your hand. And you might be able to do that just on your sort of attendee panel there. Just raise your hand and we'll unmute you as well.
Thank you, Emily and Saki and Sue, for really interesting presentation with your center. And so I am just looking to see if we have any questions in our chat, any comments.
I have a quick question, Christine, just on our end, and I wonder if Sue, you can speak a little about this. So this learning collaborative is, is going to focus a lot on those partnerships that we were talking about throughout Sue's presentation. I wonder, Sue, if you could just talk a little bit about how you, some of the strategies that you use to really start those partnerships, either with churches or universities. Do you know if there were particular strategies that were used for one or the other?
Well, the churches have the churches have changed quite a bit in this part of the city. The Resurrection Project, which is the owner of this building, originally was founded by the Catholic churches in the community. But since, I think back then there were about 8 Catholic churches, now there are 3. So they have been partners for a long time. But, I think that for lots of our partnerships with the churches and other community organizations, with elected officials, you just have to get out and talk to people and figure out what can be better. So I was trained as a community organizer back when I was in my late 20s. We talk a lot about mutual self-interest. About what we can do for each other to serve the community. And I think that that's one of the key messages, is always kind of referring back to your mission. Is this moving the mission forward? And providing excellent services that gets people in the door.
Great, thank you so much, Sue. I'm looking to see if we have any questions that have come up. I don't see anything yet. And so, Sue, this is Christine. I wanted to ask just to dive into building those relationships a little bit more. I think just to have a sense of, was it a one-time conversation, or is it something where you had to really go back several times and engage with your partners and really, like you said, make it mutually beneficial?
It's generally not a one-time thing. It's generally especially in the beginning, it can be time-consuming and labor-intensive, but it pays off in the end. We work with a local alderman's office, a health center in Stickney Township, with an organization called the Workers' Educational Society, an organization called the Latino Alzheimer's and Memory Disorder Alliance, and they are based in, they have an office in Cicero and an office in Melrose Park in suburban Cook County. We work with a parish in Little Village, a hospital in Marquette Park. We are also at each of our offsites at least one day a week, at our own clinic offsites. Then also at a place called the Back of the Yards Neighborhood Council, and we are close by to the Mexican consulate out here, and one of my other programs manages what they call the Ventanilla en Salud, so they do a lot of health promotion there. So we've been at some of those places for, like I said, about 5 years, and all of them have benefited from having us there, because sometimes we're the first person in their organization that they see. And the medical center itself has, we have an ability to be the first friendly person that people see. And while we don't say, oh, you have to go to Alivio Medical Center, we can certainly say, Alivio Medical Center is a great place. You should check it out. So it's being willing to put yourself out there, I guess.
Okay, thank you.
And we have a fairly small staff. My team is me and 6 other people, three of whom work part-time. So it's not a great big team of people who are doing the work. Also, at different times, done chronic disease self-management programs, and our lay health promoters also are doing some evidence-based programming like that with both on diabetes and Alzheimer's.
Looks like we did have a question come through, Christine, from Joanna.
Emily, can you read that? Because I'm not seeing questions, unfortunately.
Oh, no problem. Sure.
I'm not a very good moderator.
No, that's okay. Sorry. Yeah, it looks like Johanna asked a really good question, which actually I was curious about as well, is how are the services provided in partnerships funded? In other words, is it through a joint grant? Does one of the entities provide funding? Which other resources are provided by the other partner, et cetera? So that's a really great question, Joanna, and something that I think we're going to talk about a little more in the Learning Collaborative. But Sue, would you be able to speak to that a little bit?
Yep. We originally had funding through the National Council of La Raza, which is now called Unidos US, and we still get some funding from them for various programs. Not a lot of money. It's never a lot of money. My salary is now in our HRSA grant, the general grant. We get funding from the National Council on Aging for our Benefits Enrollment Center, Benefits Enrollment Center services, and also from the AAA in suburban Cook County for targeting linguistically isolated people, culturally and linguistically isolated people. And then we sometimes get grant funding from the state of Illinois, the Senior Health Insurance Program. And again, I think I said earlier that we do not get any we have not had any funding from the city of Chicago to date. We have a proposal into them because they finally decided that it would be good to pay us to do this work. And so we're expecting an answer from them this month. We have also gotten funding in the past from the Retirement Research Foundation, but the Retirement Research Foundation, like lots of foundations, give you funding to start something, but not to keep it moving long term. And that's an issue.
Thanks, Sue. I have a quick question. I know we're at time, but I was just wondering if you could answer one more question quickly. One of the issues and challenges that the Learning Collaborative participants mentioned is translation, providing services in other languages. And I know you all don't provide translational services, but you have, bicultural staff, bilingual staff. Have you attracted that staff to your health center, or do you have any suggestions to these health centers that are trying to increase their language services on what they should do?
Because of where we are, it's not been an issue for my department and the departments that I supervise. I think the side is a little bit different. Our new executive director or chief operating officer is a woman named Esther Corpus, and she's been in the healthcare field for a long time, and one of her strong suits is recruitment of healthcare professionals. But we find them, we recruit them, we train them, we help them do the work, and then sometimes they move on. It's not easy to keep. For example, I think since I've been here, we have had 3 certified diabetes educators. I think all of them were dietitians. And our last one, we've lost all 3 of them. And it took us about 6 months to recruit the next one. And he just started. But it's a challenge.
Thank you. Thank you so much, Sue. I know we're at time. So, Christine or Emily?
Yeah, thanks everyone, and thank you again for Sue for joining us and kind of just sharing some of her experiences at the health center. I know it's really helpful to just sort of hear what's going on in the community. We'll be kind of delving into some of the ways in which you can kind of start those partnerships that Sue mentioned and sort of sustain them and obviously addressing that funding issue as well. So we would love to continue the discussion from today's module on Slack. And we also want to just remind everyone that our next module is next week at 2 p.m. Eastern. So we're really excited to be joined by Jillian Bird, an RN training manager here at the National Nurse Care Consortium for that module. So please feel free to contact us with any follow-up questions, either on Slack or via email, and we'll be happy to assist you. Thank you again for joining this module today, and we really look forward to seeing you next week. Thanks so much.
Bye.